Good afternoon, everybody, and welcome to Introduction to Neurosurgery. My name is Sarah, and I'll be giving the lecture today. Just a little bit about me, and so you can see my face since I won't get to meet you guys in person today or over Zoom. I'm from Highland, Indiana. I went to IU Bloomington and studied neuroscience there, and I am a graduate from the class of 2020. Immediately following, I did a post-grad training fellowship at Mayo Clinic and moved out here to Phoenix, Arizona, where I currently live and practice. I briefly worked in private practice neurosurgery, and now I am currently a surgical first assist PA in spine, ENT, plastics, and orthopedics. So here are our learning objectives for today. I won't go over each one individually, but overall my goal is for you guys to be a little bit more comfortable with some of the pathologies and emergencies of the brain and spine so that no matter what field you go into, you feel a little bit more comfortable calling that neurosurgery consult in the middle of the night. And I did my best to put in the notes section of every slide some more finer details of things I'm saying and to appropriately mark what is just for your information versus what may be tested information. So make sure to look there throughout this lecture. So what is neurosurgery? This field encompasses both the surgical and non-operative management of the central and peripheral nervous system. So that includes the brain, the spine, and the endovascular component, so all of that blood supply and components to the brain and spine. Just a couple of reasons to maybe consider choosing this field is that it has procedural bedside skills, it has in the OR surgical skills, and there's also medical management of non-operative conditions. There's also daily application of the physical exam and imaging correlation, so I really love how you get to kind of dabble in a little bit of everything in this field. So a physician assistant's role in neurosurgery. This is just an FYI for anyone contemplating the field, or maybe even I'm garnering your interest in it today. Your job duties can vary greatly, just like many positions, based on the surgeon or the hospital network that you work in. So in general, like during my fellowship, all the APPs and the team had a role in the inpatient, outpatient, and OR setting. So I would call that like the perfect trifecta of the field itself. So in the outpatient setting, many times PAs are going to do like a pre-op evaluation and then directing the referral if they're a surgical candidate to their surgeon. And many of them frequently do the post-op follow-up, suture removal, seeing how they're recovering after surgery. Inpatient, that's going to include rounding on your post-op patients every day, taking consults from the ER, and even covering even primary or secondary call overnight. And then lastly, in the OR, your job is going to kind of be to get that pre-op consent and see them before going to the OR. When you bring them back, you're going to position them on the table, do all of the preparation, and then essentially first assist your surgeon throughout that case according to their comfort level and your skill level. And then you'll be responsible for transitioning them to the recovery unit and doing an exam when they wake up there as well. So here is the core components of neurosurgery. It's going to involve perioperative management, post-operative management, and the outpatient evaluation and follow-up of everyone. I've kind of highlighted here that it is the correlation of physical exam and imaging findings, and correlation is the key word here because I think it's important to understand if you're in primary care, urgent care, emergency medicine, and you're referring someone to a neurosurgeon or a spine surgeon based on something you've seen in an image, but maybe the physical exam doesn't exactly fit what you're seeing on imaging. So we say correlation because you're basically not going to put someone through surgery unless their physical exam and their symptoms are bothersome enough to do something about it. So very frequently you can take an MRI of someone's back and it can just look absolutely awful, but they actually don't have a significant amount of pain, so we don't do anything about it. So just something to keep in mind as we move forward and we review the physical exam and the imaging findings, what's important and when to gauge when it is a good time to refer your patient to a neurosurgeon. So just a brief review of the physical exam components that are important in neurosurgery, which you learned in your patient eval class. So you're going to have mental status, that cranial nerve exam, reflexes, sensation, gait and coordination, motor, and then special tests that will overlap a lot with the orthopedic exam as you try to elicit if something is coming from the back or if the patient actually has hip or a true knee or ankle pathology or if it's radiating from the back. So it's important to kind of have solid physical exam skills in neurosurgery, so you know exactly what pathology is going on with your patient. So now we're going to move on to talking about upper and lower motor neuron signs. So these are two categories that can describe where a pathology is stemming from when you're doing a physical exam. So there's a lot of differentiation and a lot of description in my notes below here that you can read, but let's go over each category. So we have the upper motor neuron lesions. You're going to have hyperactive reflexes, clonus, Babinski's reflex, Hoffman sign, spastic paresis, and increased tone, and drift or pronator drift. So I'm sure reading through that, you're like, I don't know what any of those things mean, and that's okay. The best way to kind of differentiate between the two upper and motor neurons is thinking about where the motor neuron is innervating and what its job is. So when you differentiate, remember, upper motor neurons, meaning the brain, the central nervous system, are responsible for motor movement, versus lower motor neurons prevent excessive muscle movement. So you're thinking more of the peripheral nervous system. So when you have damage to these areas, they're going to be almost overactivated. So when you look at upper motor neuron signs here, you see you have hyperactive reflexes, you have spastic, increased tone and rigidity in your muscles, and you have some pyramidal signs like the drift and pronator drift. Versus when we're looking at lower motor neuron signs, you have hypoactive reflexes, you have fasciculations and cramping, then you're going to have flaccid paresis and increased tone, because that damage is to more of the peripheral nervous system, so you're going to have less of that, that reaction on those physical exam findings. So reflexes, this is some of my favorite physical exam findings, and they're super easy to do, and you can do them even in, again, primary care, urgent care, family practice. So the first one is the Babinski's. You guys learned about that. It's a primitive reflex that disappears by the time you are 1. And in adults, when you do it, your toes should flex when you drag a stimulus across the lateral aspect of the foot, called downgoing toes. And a Babinski is abnormal if your toes extend upward or are upgoing. So you might hear people say, you know, they don't often say Babinski positive or negative. They'll say Babinski's downgoing, Babinski's upgoing toes. Another one is a Hoffman sign. This is not a primitive reflex. However, it can be pathologic or it also can be normal. But again, it's important a part of those symptoms and physical exam findings. You can piece it together. So this exam finding, I'll let you click on in the video embedded in this slide. You're going to isolate the middle finger, and you're going to flick downward on the nail bed. And a positive sign is when the thumb and the first digit flex forward, and this is suggestive of an upper motor neuron lesion, such as spinal cord compression. And this one's super important because we look for it in patients who have compression to their spinal cord and the cervical spine and have a syndrome called cervical myelopathy. If you get to the point where you have a Hoffman sign, at that point you have some degree of damage to the cortical spinal tract. So super easy physical exam finding, and honestly, it's almost satisfying. If you can ever find it in a patient, you'll be excited to know that you know what you're talking about. The last one is the anal wink. So it's external contraction of the anal reflex with stimulation. So if you lose this and you try to stimulate it and you don't have it, or you have loss of anal tone on digital rectal exam, this can be a sign of compression to the cauda equina and the lumbar spine, which is a surgical emergency. Another important physical exam finding would be pronator drift. And I was told this in my training, if there was only one physical exam test you could do on your neurosurgical patients every morning on rounds, what would it be? And it would be the pronator drift test. It tells us a lot, and it's very simple to do. So what you do is you have the patient stand with their hands outstretched, their palms facing up, and they close their eyes for 10 seconds. And it's an abnormal physical exam finding if there's drift of one extremity downward, so one hand falls down, or there's drift with pronation of one hand too. If it's symmetric, if they kind of waver back and forth, that is not significant or considered pronator drift. And this is not to be confused with like a Romberg's test where you just stand upright with your eyes closed and it tests your balance. This is a little different because it tells us more about
things that are going on in the upper motor neuron tract. So there can be 3 causes of a pronator drift. Like I just said, upper motor neuron weakness, a cerebellar disease, or simply loss of proprioception. So the reason this actually happens is just interesting to know and kind of helps, is that when there's an upper motor neuron lesion, the supinator muscles in your upper limbs are weaker than your pronator muscles. So as a result, your arm drifts downward and your palm turns towards the floor because of this difference in the muscle strength.
Okay, now we're going to move on to some imaging and frequent imaging you use in neurosurgery. So plain film x-rays are super good for, just regular AP or PA and lateral views of the spine. But we also frequently use something called flexion and extension views. So that's when you'll take an image of someone either flexing or extending their neck or their lumbar spine, so you can evaluate for the stability and the alignment of the vertebral bodies in their spine with movement. Another one is the odontoid view. You'll see that a lot in people who you have suspected cervical fractures for, and it can show odontoid fractures. Also frequently is shunt setting series. So if you ever have a patient with a shunt, be aware of it. You'll want to get some x-rays of their skull anytime they have an MRI to evaluate for the settings on their shunt. And then another version of x-ray would be interventional radiology. So like in endovascular neurosurgery, we constantly use fluoroscopy for guidance and imaging in the brain. The next one would be CT. That would be with or without contrast, which is iodine in a CT. So you can have a regular CT, you can have a myelogram, a discogram, or an angiogram. And then lastly, MRIs, also with or without contrast, which in this case is gadolinium, or you'll hear with GAD. And then there's also subcategories of MRIs, such as an MRI angiogram or venogram, or even a functional MRI. MRI sequences. So when you first start out learning MRI sequences, especially in your radiology module, it can be a little intimidating and quite confusing, but the good news is there are just a few sequences that are important to you if you are not going to be using them on a day-to-day basis. So the simple, concise things I've used and what I've taught is that T1 sequence is good for outlining the anatomy itself, and T1 with GAD contrast enhances active lesions. So if you're suspicious for a lesion, you're going to do an MRI with contrast. And then T2 is sensitive for any pathology. So tumor, gliosis, demyelination, a hemorrhage, and T2 has a 2 in it, so just as H2O does. Anything that has water is going to show up bright and appear hyper intense on MRI imaging. So I gave this little chart here, just kind of FYI to know. You do not need to memorize any of this, but you will find your own method and what works for you. But just know T1 with contrast, and T2 are the 3 most crucial ones you'll have to know on a regular basis, even if you don't practice neurosurgery. Choosing imaging tips. So this is what's more important than that chart on the previous slide. If you are suspicious for a fracture or instability of the spine, you're going to be first going to plain film or a CT itself. So obviously if they're in the trauma bay, you're not going to have someone stand up and flex their neck and risk injuring their spinal cord or their arteries in order to assess for stability or a fracture. So they're going to lay down and they're going to get a CT and they're going to be in a C-collar. But if it's in the outpatient setting and they've had a fall and their back hurts, or maybe they say, when I bend forward I get shooting pain down my legs, that's when you can do a plain film x-ray, have them do that flexion extension view and assess for it, and then refer them appropriately. The second is if you have any sort of suspicion for infection or a tumor, your imaging is going to be with contrast. So if you don't know where to start, or you don't want to start with an MRI, CT with contrast or MRI with contrast. The key component here is with contrast. 3 is if you're suspicious of an acute bleed, you're going to do a CT without contrast. If you think of it on, a CT, blood is going to be hyper dense, so it's going to be bright. So your blood is essentially going to act as your contrast, which is a good way to think of it. So if you do get a CT and see brightness, it will help you identify an acute bleed like in a stroke. And lastly, if you have any concerns about the soft tissue or the central nervous system, you are going to get an MRI. So in any setting, if your patient has back pain that has been relentless, it's failed conservative measures, your next best step to evaluate for the spinal cord and the discs and the nerves is going to be getting an MRI. So now we're going to move on to the subcategories of neurosurgery, and we'll start with brain surgery. And we'll just briefly go over 4 of the main types of words or surgical procedures you hear of in neurosurgery. So this is just for your information, maybe so that you understand a little bit more that's going on with neurosurgical patients. So a burr hole is a drill that makes a small hole into the bone. And this can either be used by itself to drain blood, or it can be the initial step in starting a craniotomy, kind of like the starting point. The next one is a craniotomy, and as the word describes itself, it is the opening of the bone of the skull. Then you have craniectomy, which is the surgical removal of the bone itself. It's called a bone flap, and sometimes you put that bone flap back on at the end of surgery, and sometimes you leave it off. And the last one is cranioplasty, and that is the surgical repair of a bone defect in the skull, either by putting the patient's own bone back or printing it out with a 3D printer or using a synthetic material like PEEK and reimplanting it into their skull. And here's just a photo of those 2 things I was describing. So if you look on this left photo where that little circular hole is, that is the burr hole. And then they're using the drill to kind of connect 2 burr holes together to create the craniotomy. And then on the right-hand side here, you can see a cranioplasty in which they've taken the patient's own bone, put it back, and put some screws and bars in to hold it into place, and those will stay there.
So now we'll go over some of the brain operations and procedures that you'll hear about. The first one is the most important, and we'll review all of the types of intracranial hemorrhage and their management. That would be the most important information, especially for the pants. And then we'll review some things you do for elevated intracranial pressure, why you use a lumbar drain, shunts, brain tumors that would be removed, and some of the procedures that are endovascular neurosurgery as well. So the first one we'll review is a subdural hematoma. The mechanism of this injury is an acceleration-deceleration injury. So this can be kind of inconspicuous. Sometimes they don't make sense. Even older people on anticoagulants may not have even had any injury at all. But the injury is caused to the bridging veins within the brain. So the bleeding occurs between the dura and the arachnoid and pia mater layer. So that's why it's called a subdural, meaning below the dura. Symptoms of a subdural, they can also be kind of inconspicuous, so always have it in the back of your mind. Headaches, insidious mental deterioration over days or weeks. They may have focal deficits on a neuro exam, or they could be completely fine. They could also have signs of herniation, and they could almost be comatose and have no neuro exam if their subdural is big enough. So something to always keep in the back of your mind in all patient populations, especially the older generation that has some brain atrophy or maybe on some anticoagulant medications. And lastly, to diagnose a subdural hematoma, it's going to be a CT without contrast. How we talked before about how if you have suspicion for a bleed, you're going to go for a CT without contrast first. And your keyword here will be a hyperdensity in a crescent shape that crosses the suture lines in the brain. And that makes sense anatomically if you think about it, because it's underneath the dura, so there's nothing stopping the blood from spreading across, one whole hemisphere of the brain, because the suture lines don't connect with the dura in any way. It is important to note that the appearance of a subdural changes with the age of the subdural. So in acute, the blood is going to be hyperdense and bright, as seen on the left here, less than 72-hour time frame window. Then when we move into the subacute, it becomes isodense and almost the same appearance as the surrounding brain tissue nearby. And then chronic, greater than 2 weeks old, will be hypodense on CT and appear dark. And as subdurals that were non-operative or were not drained age, they can stay for months and months and months as they heal and resorb. So these can take an appearance that if you come across it in your practice in the ER, you would know that it is chronic and not an emergency at that time if it has this appearance. So subdurals can be managed both operatively and non-operatively depending on some numerical values. So if the thickness of the subdural itself is greater than 10 millimeters, or there is a midline shift greater than 5 millimeters on CT scan, you're going to probably do a surgical intervention to relieve that pressure. There are some other more nuanced values I've listed here of why you would, maybe initially not operate on this and then change your mind and take them to the operating room. But overall, you don't need to memorize any of these values. Just understand that although these guidelines provide a framework, you need to have good decision making. It's important to consider the overall clinical picture of the patient, and if they're going to have an easy recovery from this, if it's against the patient or the family's wishes to operate on them, and overall how they will do afterwards. The next topic is an epidural hematoma, and the mechanism of this hemorrhage is blunt force trauma to the skull. It usually has an overlying skull fracture to that area, and it is due to injury to the middle meningeal artery with bleeding between the skull and the dura. So epi, meaning upon the dura itself. The presentation of these injuries is going to be head trauma with a brief loss of consciousness. They're going to have this lucid interval, and then they're rapidly going to deteriorate and have a worsening exam. Symptoms is declining mental status, unilateral pupil dilation, hemiparesis, or even coma. You're going to diagnose this again with a non-con CT head, and the appearance of it is going to be a lens-shaped hyperdensity. So there's your keyword there to look for that in the vignette in diagnosing this. The reason this is lens-shaped is because it is upon the dura. So the dura has those little sutures that connect it to the skull. So as the blood expands, it has nowhere to go except for inward. So it creates this kind of lens-shaped appearance on the CT imaging. And the intervention for an epidural is going to be burr hole evacuation or decompressive craniotomy. So you're either going to drill a small hole to relieve it, or you're going to take a big chunk of that bone off to relieve the pressure and drain the blood. Oftentimes, these do require operative management. They aren't something you can sit on unless they're very small. So for the most part, if you see this in your practice, you're going to be calling an emergency call to neurosurgery. Again, this is just an FYI. You don't need to memorize any of these volumes of the epidural hemorrhage because if you're not practicing neurosurgery, you don't need to know this. You just need to call the consult and know that this is usually a surgical emergency. So most important slide for some PANCE buzzwords, and the way that I think is best to learn the difference between a subdural and epidural is that subdural has a B in it, and it's going to have that banana appearance because it is beneath the dura. There are no sutures that are stopping the expansion of blood, so it can fill one hemisphere of the brain. Versus an epidural has an E in it. It gives you that lemon appearance. And it has that lens shape and is more convex because the blood is being stopped by the suture lines between the dura and the skull, so it expands inward and gives you that nice crescent shape. I think this is a really helpful slide, and it will be on your pants. The next hemorrhage we'll talk about is a subarachnoid hemorrhage, and this is a hemorrhagic collection within the subarachnoid space between the arachnoid and the pia mater. The most common cause of these is a ruptured aneurysm, and usually these present as people with sudden onset, quote, worst headache of my life, end quote. So that is used a lot in vignettes if you come across that on any of your exams. Symptoms will be variable, but it will often be headache, stroke-like symptoms, some neck pain, or a focal neurological deficit on exam. Diagnosis will be, again, non-con CT will show you a hyperdensity in the basal cisterns. But subarachnoids can happen in many different layers in this. This is just kind of the classic presentation you see in the picture here, known as the star of death. You can kind of see that hyperdensity makes the shape of a star in the basal cistern. You can grade subarachnoid hemorrhages with the Hunt and Hess score and a modified Fisher score, which you don't need to memorize, but it is helpful in understanding, if you're taking care of a patient who has a subarachnoid, these can kind of tell you morbidity and mortality and severity of their injury. There is a genetic predisposition that I think is helpful to know. Those with autosomal dominant polycystic kidney disease are at risk of having subarachnoid hemorrhages because they do develop aneurysms. May or may not be on your exams, but in my clinical practice, I've already come across somebody who was at predisposition due to this. The management can also vary for these. They don't necessarily have surgery. You could have an EVD placed, which is an external ventricular drain. We'll go over that in a few slides. Some of these people just get medical management and prevention and treatment of vasospasm. So what that means is sometimes you're just letting the brain have time to heal from this, or they may need an endovascular treatment where they go in and get some coils where their aneurysm ruptured. As blood fills the brain, it can kind of rub on and irritate those arteries so they can spasm and kind of vasoconstrict, and they can have stroke-like symptoms. So you basically just need to keep these people's blood pressure under control, keep them well hydrated, and they often have long recoveries and long time spent in the ICU as the brain heals. So here are both those Hunt-Hess and modified Fisher scale scores I was referring to. Hunt-Hess is going to tell you the severity of their hemorrhage and help predict survival, so their mortality rate from it, versus the modified Fisher scale is going to be used to predict cerebral vasospasm. And as you can guess, the more blood that there is seen in the imaging and on the brain, the higher risk of vasospasm. And lastly, the two other types of hemorrhages you would hear would be an intraparenchymal and an intraventricular hemorrhage. Obviously, the words kind of help explain themselves. So intraparenchymal means you're going to have blood within the brain tissue itself. So it's not going to be like those other ones we learned where they're like on top of the dura or below them, or within the arachnoid and pia mater. These are actually within the tissue. And then intraventricular is blood actually within the ventricle space itself, as seen in the picture on the right. These are just FYI, so you have a clear picture of all the areas in the brain that you can have a bleed. So the concept of elevated ICPs or intracranial pressure can be applied to all of the aforementioned hemorrhages we just reviewed, as well as a traumatic brain injury without a hemorrhage that just causes elevated intracranial pressure from the brain tissue itself being injured in edematous. So the skull is a fixed space, and it has 80% of the brain parenchyma, 10% of that is the CSF, and 10% is blood. And if you remember from pathophysiology, the Monroe-Kelly doctrine says as one of these volume increases, another must decrease. So if you're in a fixed space, the tissue itself is going to be pushed out and you can herniate, and then that's how you can have brain death, is that the brain tissue has nowhere to go. So a normal intracranial pressure is less than 15 millimeters of mercury, and it can become pathologic when it's greater than 20. And causes of intracranial pressure can be a mass, like a tumor, the hematoma or hemorrhages we discussed, edema from a head injury, increased CSF production with nowhere for the CSF to go or exit, decreased absorption of the CSF. Your brain, while it makes it, also absorbs it too. And then obstruction of CSF leaving the body, or idiopathic. So you might remember like idiopathic intracranial hypertension, where we don't know why it happens necessarily. Signs are going to be headache, nausea, papilledema on an eye exam, confusion, and decreasing consciousness over time. And when it is really severe, there's Cushing's triad, and that is the three components of bradycardia, respiratory depression, and hypertension. And that's because there's pressure on the brainstem, so you're going to get all these changes in the autonomic nervous system itself. So treatment of elevated ICP is important for everyone, regardless if you practice neurosurgery, especially if you're the first person to come across somebody with elevated ICPs in the ER and the ICU. So the first thing is elevating the head of bed and keeping the head midline. So you elevate the head of bed because of gravity. If you lower your head down, ICPs do increase. You keep the head midline so that the head is not turned or cockeyed and then compressing the venous return to the neck, and therefore increasing ICP if you're blocking venous drainage. The second is hyperventilation. This is less commonly used but still important to know because inducing hypocapnia reduces the partial pressure of carbon dioxide, and this causes vasoconstriction. One of those fun things we learned back in pathophysiology. So if you create vasoconstriction, you're going to decrease the blood flow and the volume, so then you're decreasing one of those components of the Monroe-Kelly doctrine, and decreasing ICP. The next one is hyperosmolar therapy or hypertonic therapy. You'll hear this with like IV mannitol or hypertonic saline. And when you do this, you create an osmotic gradient and you shift some of the CSF into that hypertonic space and reduce the ICP as well. Another one is sedatives such as propofol or benzos. These aren't initially used when somebody has increased ICP. Maybe it's, after you've intubated them or you're waiting to take them to the OR, or even just while they're in the ICU healing. So when you give someone a sedative, it reduces the metabolic rate of oxygen consumption, and this is going to decrease the cerebral blood flow because you're consuming less oxygen for brain function, and then therefore you're decreasing ICP. And then lastly is direct decompression. So that's either going to be that craniectomy where we remove a piece of the bone and directly make more space for the brain to expand, or you're placing an EVD, a drain, into the ventricular space and diverting CSF out of the brain or blood out of the brain to create more space for brain tissue itself. So I've mentioned an EVD in a couple of slides, so let's finally go over what that means. So the purpose of an EVD, or an external ventricular drain, can be both therapeutic and diagnostic. So it can give you ICP readings. There's monitors on them that tell you the pressure within the brain. And it also can be therapeutic because it can shunt CSF externally to relieve increased ICPs. So the indications for them are obstructive hydrocephalus, meaning increased CSF within the brain. This can be caused by a bleed like a subarachnoid hemorrhage or lesions with a mass effect within the brain. The placement of an EVD is that you make a burr hole at this certain point on the skull called Coker's point. I've listed it here. And you're placing this catheter into the frontal horn of the lateral ventricle at the foramen of Monro. You don't need to memorize any or all of that, but just know that there's a certain place that you aim to place the EVD catheter that helps shunt CSF out of the body. The risk of putting these into the brain is creating an intracranial hemorrhage while you place it, and you can get ventriculitis and get infections by introducing a catheter into the brain space itself. But this is just kind of helpful to see that if you see a patient with one coming out of their skull, that's what that's what it is, and its purpose can be both therapeutic and diagnostic. So this is just a picture to understand what an EVD is. So on the left, you're looking at them placing it in the entry point at Coker's point. The middle picture is tunneling the catheter of the tubing under the skin away from where you had the entry. This kind of helps prevent infection if the tubing isn't directly communicating with the space where you placed it. And on the right, this is the actual external drain with a collection bag for the CSF. Super helpful to know. These generally all look kind of similar no matter what hospital system you work at. It'll have this little ruler on here that shows you the ICP levels, and then there will be like a 0 point where it should be even with the patient's tragus. And that's how you measure the ICPs. And then this chamber that's kind of has blood in it right here, it has some bloody CSF, drains and diverts that extra fluid out of the body into this collection bag. There are also ICP bolts. This is just an FYI. If you see something else coming out of the brain that isn't an EVD, these can be placed in the parenchyma, in the subarachnoid, epidural, ventricular space, what have you. Their only purpose is to monitor the ICP. So a bolt is not therapeutic like an EVD. It can't drain any blood or fluid away. It's just to look at somebody's ICPs. They're less frequently used now because if you have an EVD and you can do something about it, you're often going to place that instead. Patients suffering from traumatic mass lesions and with GCSs less than 8 are candidates for these rather than an EVD implant, since most of these patients have physiologic ICP pressures. So they're not developing hydrocephalus and they don't have, increased production of CSF or blood, so they don't require their CSF to be drained. It's just that the brain is responding to an injury with edema and expanding. So just an FYI to know that bolts do exist and sometimes you will see them. And here is a picture also for understanding of what a decompressive craniectomy is. In this instance, this gentleman had his bone flap removed and kept off, and then you close the dura and you close the skin over it, and they live like this, sometimes for like 6 months or more as they heal. And then you can actually go back and do that cranioplasty where you can take their bone flap that's usually been frozen and sterilized, or they've had a synthetic material printed to the shape of their skull and go back in and place it at a later date. Shunts are another form of diverting CSF, and instead of being like an EVD where the tubing is coming out of the skin into a bag next to you, a shunt actually diverts the CSF into usually your abdominal cavity. So indications for this are hydrocephalus, macrocephaly in children, idiopathic intracranial hypertension, and normal pressure hydrocephalus. So you usually place these again in the frontal horn of the lateral ventricle, and then they tunnel the catheter under your skin, down your neck, and then usually it'll either be in the peritoneum, just dripping slowly. It can be in the pleural space between your lung, and you can even have them drain into the cardiac atria too. So also just knowing that these exist, and if someone has a history of one and they're obtunded, that can mean that their shunt is blocked off or clogged somewhere, and then they've become attunded because their ICP has increased. So super important to be aware of the history of patients who have shunts for presentation on exam, or if they have an MRI, this can mess with some of the settings on their shunt. So you need to be aware of if you ever scan somebody who has a shunt and how you can fix that afterwards. Another way to divert CSF would be with a lumbar drain. So same thing as an EVD, but now we're placing it in the lower back, in the lumbar space, and in this catheter is sitting within the space of the cauda equina. So this decompresses the CSF space. It can also be used for the management of intracranial hypertension, or to repair a CSF leak or a fistula, or in the evaluation of normal pressure hydrocephalus. The risk of doing this is that you can over or under drain CSF. You can also, expose them to infection or give them meningitis. A contraindication to this would be obstructive hydrocephalus, because if you're draining space below the level of the brainstem, you can make it worse because you're over shunting them, and you can cause brain tissue to actually leave the brain itself. So here are two brain neoplasms that are pretty common, and I think are just the two most important to kind of know that exist. The most common benign is a meningioma, and this actually is a benign lesion that arises from arachnoid cap cells. So it doesn't actually grow from the meninges of the brain, it's the arachnoid cap cells, so it's a little bit of a misnomer. But these are usually hyper intense on imaging, and they have a dural-based tail that enhance on CT and MRI. So in the left picture here, you can see it's nice and smooth and round, and it actually has this bright little tail coming off of it on the bottom. So that's kind of a pathognomonic for a meningioma. And on the right, you're going to have a glioblastoma, and this is the most common primary brain neoplasm. On imaging, they often have really thick, irregular, enhancing margins and a centrally necrotic core. So it's usually necrosing centrally and then growing peripherally. Sometimes they have a hemorrhagic component and can be bleeding within their brain tissue. They usually have vasogenic type edema around them. Like it can be almost the entire hemisphere has edema due to this mass growing. And it usually also has infiltration of those brain cells. These are very aggressive brain tumors that unfortunately do not have any cure. And a lot of our interventions, both surgically, radiation, and otherwise, are just to extend life. And lastly, we will review endovascular neurosurgery. So this is the components that involve interventions by going in the endovascular spaces. And oftentimes this includes for treatments of aneurysms, arteriovenous malformations, a stroke, and an intracerebral hemorrhage. This is just FYI so that you know it exists. This is just knowing some of the interventions that occur with endovascular neurosurgery. So, for example, like a stroke is going to have a thrombectomy. You can take them back to the suite, run a catheter up their groin, up to the brain, and actually retrieve the clot that is causing the stroke and the tissue ischemia. Aneurysms can be coiled, stented, embolized, or even have an open brain surgery to clip the aneurysm. AVMs also can have coiling, embolization, or open surgical resection. And then intracerebral hemorrhages, you can go in and embolize where they're bleeding into those feeding tissues, like in a subdural or an epidural hemorrhage. You can actually have endovascular management as well. So next we are moving on to spine surgery. So I've listed here some terms that you'll frequently hear that are involved in what spine surgery is. You do not need to memorize these, but if you understand what the anatomy is, you'll understand what the surgical procedure is. So the list of those definitions are in the description below. So this is just a list of the topics we're going to go over in the spine portion of the lecture. So the big picture takeaway I just want to note with back pain and back injury is that pain can come from many different parts of the spine anatomy itself, from the muscles, the ligaments, the bony structures, the discs, and the nerves. It can also be referred pain, as I'm sure you've learned in some physical exam classes. So just something to keep in mind that not everything that happens needs an operation or even treatment. And you also don't need to jump to imaging right away when somebody has acute back pain. So a lot of it is self-resolving, but there are many different reasons why people can have back pain. So we're going to start out with the topic that's most applicable to everybody, which is going to be low back strain in general. So this is a non-operative, just run-of-the-mill, one of the most common causes people come to the doctor, urgent care, ER, what have you, and is a huge issue we face in healthcare costs today, and a reason people miss a lot of work. It's usually due to bending, twisting, or a lifting injury of the back, especially repetitively. These patients are not going to have symptoms in their lower extremities, so they're just going to be holding their back. It might be radiating, maybe into their buttocks or in the area of the injury, but usually they don't have sharp shooting pain going down their legs in the radicular distribution, which we'll go over on the next slide. So this is called axial low back pain. Their physical exam is going to show that they've had guarded movements. They're not going to be really willing to let you do anything to them. They're going to have muscle spasms you might see, and they're going to be tender to palpation along those muscles that are sore. The diagnosis is clinical, and there's no imaging necessary for acute low back injury without lower extremity symptoms. Do continue to use your clinical judgment, though. If they have a history of cancer, or maybe they had a more traumatic injury to their back, you can always get imaging, but if it seems non-suspicious, you don't need to get imaging right away. Save the patient some money and treat them conservatively. So treatments are usually an anti-inflammatory, a muscle relaxer, heat and ice, and active rest with PT and frequent movement. So this just means, they can rest and put heat and ice on it, but then they need to get up and get moving around and start using their back muscles again. They do not need bed rest, and that's the most important thing I try to stress to people. And then just of note, opioid medications are not recommended for acute low back pain. Usually you can get people's pain pretty much under control with Tylenol, NSAIDs, and muscle relaxers. Overall, it's just self-limiting, and it will take time to resolve. If the pain is persistent at the 4 to 6 week mark, then that's when you can reconsider obtaining imaging like an MRI. Another cause of back pain that's important for everybody to know is vertebral compression fractures. This happens when there's a fracture or just compression of the vertebral body itself. And there's usually an underlying reason why this happens. So it could be that you have osteoporosis, or you have a tumor in the body, or maybe you've had a high velocity injury in the younger population. But typically these do happen in the older population, and they're usually a low impact injury, like they've fallen just from standing height, or even they've had no history of trauma at all. I've seen patients where they just, they sneezed really hard and then suddenly they had intense back pain. There are 3 different types of compression fractures: wedge, burst, and crush. And as I said, these present as intense back pain. These patients cannot get comfortable. They're extremely tender to palpation, and you can perform something called a tap test, which is exactly what it sounds like. You make a fist and you kind of just tap semi-gently along the midline spine, and it will regenerate the pain they're feeling and help you localize where the compression fracture is. Diagnosis, since it's a bony injury, will be X-ray or CT, and you're going to treat these with opioid pain control and anti-inflammatories. It is indicated in this instance. Like I said, it's usually the older population that gets these. There'll be low risk of abusing opioid pain medications, and these are actually extremely painful injuries, so treat them accordingly. You're also probably going to place them in a brace, but my general consensus is to page whoever's on call with your spine team for recommendations on what type of brace, how long to keep them in the brace, and if the compression fracture is actually severe enough, do they need to be considered for a procedure like a
kyphoplasty, vertebroplasty, or maybe even a spinal fusion. So when I was talking about that sharp shooting pain going down the legs, if you remember from your physical exam class, you have dermatomes, in which we feel the sensation in certain distributions from our sensory nerves through our body, and then we also have myotomes, which are the muscles that are innervated by a sensory nerve. So if you see someone with a low back strain after they lifted something extremely heavy and they have back pain that's radiating all the way down their leg, down to their ankle or into their big toe, you can be a little bit more suspicious that they've had an acute disc herniation because they have radicular symptoms of pain or numbness or paresthesias or maybe even weakness. Your physical exam is going to be super important here, and then it can also tell you, if someone has weakness, you're going to be a little bit more inclined to get imaging and act promptly to preserve whatever injury or compression they have in the nerve versus somebody who maybe just has pain but otherwise has a normal physical exam, and you can treat them conservatively because most disc herniations will resolve on their own. I think the number is upwards of 80%. So just because they also have radicular symptoms doesn't mean you have to jump to MRI imaging, but your physical exam is your best friend in cases of low back injury. So radiculopathy can be caused by a variety of reasons. So this could be structural, meaning there's an acute herniation of a disc, or degenerative disc disease that is causing the space to become thinned out between the intervertebral discs and narrowing where the nerve is exiting. You can also have facet hypertrophy, and the way I describe it is the same way that people get, bigger joints in their fingers with arthritis. You can have arthritis in the facet joints of your back. And so as those joints get bigger and grow, they narrow the space and the foramen where nerves exit and can pinch them. And you can also have spinal instability. So you can have slippage of the alignment between your discs, and as they slip, those also decrease the space and can pinch the nerves as well. So radiculopathy can be caused by multiple things besides just a disc herniating onto the nerve itself. The symptoms are going to be those radiculopathic ones we reviewed, so back pain with radiating sharp pain down the leg, paresthesias, numbness, or weakness in the distribution of the affected root. Diagnosis, this is referring back to when you need to think about if you have concern for the CNS soft tissues. So we do. It's going to be an MRI with and without contrast, and contrast in an MRI is gadolinium or GAD. Treatment is initially conservative if you're the first one seeing their back pain. If it's like an acute disc herniation, and they do resolve most of the time in 4 to 6 weeks. If it's structural and if it's like slippage and it's a chronic issue over time, that's when you're going to be more suspicious when they fail conservative therapy, and you're going to refer them to a surgeon. And the treatment for this can be a discectomy and or a fusion, and we'll get to the reasons why you would fuse the spine versus just doing a discectomy or a laminectomy in someone in the next slide. Sometimes the cause of radiculopathy is a disc herniation, and you don't just do a laminectomy to relieve the space. You can actually pluck out the piece of extruded disc if you're able to. Sometimes the anatomy and adhesions don't always make that possible, but in instances when you can, that's called a discectomy. This can be open or minimally invasive. So open meaning it's a bigger incision, you're kind of exposing a lot more anatomy, versus minimally invasive is more endoscopic and done in a small tube where we can kind of get down to the anatomy, drill away, and pull the extruded disc out. So this page is just a visual and an FYI to understand. So you can have decompression, so relieving what's causing compression on the space of the cord or the nerve itself by doing a laminectomy, laminotomy, or facetectomy. So if you look at this picture in the bottom right corner, you can see the lamina or the roof of the spine can be decompressed by drilling it out. So in that picture right there, that's a hemilaminectomy. Because they've drilled out half of the lamina. You can remove this whole thing. And then you can also do a laminotomy if you know there's just a smaller space that's being affected, and you can drill just a small hole to relieve tension or pinching on a nerve root. And then a facetectomy is going to be removal of parts of the facet joint. So you have every disc has a superior and an inferior articular process that make the facet itself, and you can drill out about 1/3 of the facet joint if it's causing narrowing on the spinal nerves without causing instability. There are instances when you can't preserve the stability of the spine when you're decompressing it, whether they have degenerative disease or scoliosis, or they've had prior laminectomies. So sometimes you can take away enough bone that you're now causing iatrogenic instability, and that's when you have to do a fusion and actually put in screws and rods and cause the spine to fuse itself as if it was broken. You're going to make all those bones fuse into one solid block, which is why it's called spinal fusion. So as I mentioned before, the goal is often decompression, but sometimes you have to add instrumentation, which is causing spinal fusion. So you can fuse anywhere in the spine between two vertebrae with the use of instruments, and auto or allograft, meaning you're placing a graft with the patient's own bone and tissue or bone marrow aspirate, or you're using something that's synthetic in its place, and it's going to cause the bones to grow together. So this picture up here on the top, you can see the screw heads and the rods between them. And then where there used to be an intervertebral disc, there's now a cage. And often we pack that cage with the auto or the allograft, and then over time, usually over 6 months to a year, the bone then begins to fuse into one solid block of bone and fuses the spine so it's not unstable anymore. And fusions can happen in multiple ways. So if you ever see it in documentation or the patient's trying to tell you, you can have fusions on the neck that go from the front, which would be an anterior cervical fusion. You can have the lumbar can be done from the side, from the front, the back. So those are all of those words like T-lift, P-lift, O-lift, A-lift, X-lift tell you the direction the surgical approach was. And that's just to say that you can do the surgery from a variety of different angles and mechanisms. So next we're going to move on to cord compression, and we'll start with the cervical spinal cord. So you can have cord compression as seen in this MRI here, where the area is really tight and you can kind of see the spinal cord does not look happy. But there's also a clinical syndrome you can get called myelopathy when you have spinal cord compression. These don't necessarily go hand in hand. You can have a really bad looking MRI and patients don't have symptoms, but that doesn't mean you don't have to do anything about it still. We still want to protect the spinal cord. But if you do have the constellations of symptoms, you can clinically diagnose someone with cervical myelopathy. It'd be a great catch, and you'd be able to refer them to a spine surgeon to take care of it. So cervical stenosis that causes the compression can be caused due to like a large disc herniation compressing it, or a degenerative disease of the neck over time, or a trauma. So symptoms, they usually have neck pain and stiffness. They usually have issues with fine motor skills of their upper extremities and their fingers. They can have a loss of balance and trouble walking as well. On physical exam, you'll notice they'll have like decreased grip strength. They'll be hyperreflexic. They'll have that positive Hoffman sign we talked about in the beginning of this lecture. They'll have some gait instability, kind of be off balance, and usually have some impaired dexterity. Some of the things I frequently realize patients say when they have this syndrome is that they're dropping things more often. They think they're gripping it really hard. They have difficulty buttoning up their shirt, doing anything that requires two-finger grasping, things like that, or that even their penmanship or their signature has changed because they have difficulty holding a pen. So because we have concern about the soft tissues, your diagnosis is going to be an MRI with and without contrast. And then this will show you the cord compression. You might see something called cord signal change. So if you see that little white blip kind of in the center of the spinal cord in that MRI, that is cord signal change, and that already indicates a degree of injury to the cord, and you'd want to get them referred ASAP. The intervention is going to be decompressing and fusing the spine. So your patient will maybe get referred for an anterior cervical fusion, a laminoplasty, or a posterior fusion of their cervical spine. Here is a picture to help visualize what those surgical interventions would be. So that ACDF is an anterior cervical discectomy and fusion. You go through the front, and then you can also have a laminoplasty,
in which you opened up the space for the spinal canal without removing anything. So you basically make almost like a door hinge is the best way to describe it. Place this little plate across it and it opens up and creates more space in the spinal canal. Another form of cord compression would be in the lumbar spine in something called lumbar stenosis. So this one is super helpful, and it will be on your pants. It's most commonly caused by spondylosis, which is just a fancy word for saying degenerative spinal disease. So their presentation will be back and leg pain, worse with standing or walking, and relieved with sitting forward or lying down. This is because when you stand up, you're making the space in your spinal canal smaller, and when you bend forward or do that shopping cart sign where they're leaning forward, you're flexing your back and you're opening up that space and decreasing the pinching of the cord. So their symptoms are going to be neurogenic claudication, back pain, and bilateral leg weakness. Diagnosis is once again going to be with MRI, with and without contrast, and the intervention here can be a laminectomy, where you go in and remove the roof portion of the spinal canal to open up that space, and they may or may not need a fusion dependent upon some of those factors we talked about previously. But spinal stenosis will not get better without a surgical intervention most of the time. Another form of a spinal cord compression that's an emergency, and you should know this slide, is cauda equina syndrome, and that is when you have compression of the cauda equina itself. It can be caused by an acute disc herniation that's huge. It can be caused by inflammation, an abscess pressing on it, a lesion that's growing, or severe spinal stenosis. This is a surgical emergency. You're often taught that there's a triad of symptoms, which would be saddle anesthesias, numbness in the in the medial parts of the thighs, bowel or bladder dysfunction, and lower extremity weakness. I say bowel or bladder dysfunction because I think that sometimes you're taught that it would be loss of bowel or bladder and they're just urinating without knowing, but pretty frequently you can actually have urinary retention and bowel retention when they haven't been able to go despite having the sensation. You can also have symptoms of back pain and leg pain and sexual dysfunction as well. On physical exam, you're going to do that lovely digital rectal exam to look for loss of anal tone and look for lower extremity weakness and numbness in their saddle anesthesias. Diagnosis: MRI without contrast, and intervention is going to be an emergency decompression in some way, shape, or form. So next we'll talk about spondylolisthesis, which is again another fancy term that describes slippage of the vertebral bodies on top of each other. So the mechanism is spondylosis, so degeneration of the spine causes spondylolisthesis, the slippage. Symptoms are going to be maybe spinal stenosis or radiculopathy, so they can have signs of the neurogenic claudication with standing, or they can have shooting pain down their leg that gets worse with certain movements like standing or flexing their back. Once again, diagnosing with an MRI with contrast, and the intervention is going to be to decompress them and fuse them. It's important to know that slippage can have a grade. So there's, on this picture here, you can see there's grades 1, 2, 3, and 4. And not often can you have a degree of slippage that actually doesn't need surgery. So just because you have slippage doesn't mean that that slippage moves. That's why we get flexion and extension x-rays of the back, because you can have slippage and do those images and that doesn't move at all. Oftentimes, though, grades 3 and 4 do not respond to non-surgical therapies, and they often are unstable, and you have to fuse their spine. So something just to mention and to be aware of in your practice is that there is something called adjacent segment disease. So if you have a patient who had a prior back fusion, the area where the bone fuses together and becomes a solid block then adds extra stress to the vertebral bodies above and below it. So you can get accelerated degeneration at other levels and need another fusion where they go in and either take this hardware out or extend it and make it longer due to the excessive wear and tear on the surrounding areas outside of the level where they've had a fusion. Lastly, we are going to talk about spinal cord tumors because they are something that can occur when somebody's having back pain or pain going down their legs that necessarily aren't due to, a disc or the bone or their degenerative spine disease. So we'll talk about the three most common types, and there's intramedullary, meaning within the spinal cord itself, intra meaning within. The most common is an ependymoma, which is benign but can, in severe cases, become malignant. We'll talk about intradural, extramedullary, so within the dura of the cord, but outside of the cord tissue itself. And these can happen, and it can be a meningioma, schwannoma, or neurofibroma. And then extradural, meaning it's growing completely outside of the cord and the dura, it's just in the space of the spinal canal. The most common is often metastases of other primary cancers. Well, thank you all for your attention today. To wrap everything up, we have 3 cases I'll walk you through, and the answers and written explanations are also in my recommended resources slide at the bottom. And please do not hesitate to email me or reach out if you have any questions or concerns about any of this information. Since it was asynchronous, I can always get back to you as soon as possible with answers. And thank you again for your time, and good luck on your test. So case 1, we have a 7-year-old female who presents to your urgent care, and she has complaints of bilateral hand weakness. She says she spilled coffee down her shirt, and she's unable to grasp her cup in the morning when she's drinking it. She complains of some neck stiffness, but otherwise denies any pain in her upper extremities. She does report some numbness in her fingertips. On exam, you notice she has a bilateral Hoffman sign. What other physical exam finding would you most likely see with this diagnosis? A, no biceps reflex. B, flaccid paralysis of her upper extremities. C, a positive straight leg raise. Or D, hyperreflexia. So I'll just give you a moment to think about your answer. So the answer for this one is going to be D, hyperreflexia. This vignette is giving us signs and symptoms for cervical myelopathy. And if you remember, cervical myelopathy is going to have upper motor neuron signs due to cervical cord compression. So if you have a Hoffman sign, you can think right there that's an upper motor neuron sign. I will look for other upper motor neuron sign, which would be hyperreflexia. A is going to be lower motor neuron, so will B, and then C is unrelated, has nothing to do with the cervical spine. You would see that, in a disc herniation. So that is why D, hyperreflexia, would be our best answer. Case 2. A 62-year-old man presents to clinic with complaints of back pain with radiation down the lateral portion of his left lower extremity into his foot. This has progressed over 12 weeks. He describes it as sharp, stabbing pain and now has associated numbness and weakness when walking. On exam, there's 3 out of 5 strength with left dorsiflexion. You order an MRI of the lumbar spine, which shows a large lateral disc herniation at L5-S1 and grade 3 spondylolisthesis. What would be the next best step for his care? So A, we have order a muscle relaxer, an NSAID, and a course of physical therapy. B, refer him to a spine surgeon for emergency decompression. C, order CT lumbar spine with and without contrast. And D, referral to spine surgeon for decompression and fusion. So I'll give you another second to think about what answer you'd like to choose. And the answer for this one is going to be D, referral to a spine surgeon for decompression and fusion. A is incorrect because this would be for an acute disc herniation that hasn't been going on for a long time. This gentleman has had these symptoms for over 12 weeks, and now he has pain, numbness, and weakness. 3 out of 5 strength is pretty significant on exam. And his imaging shows that he has a large lateral disc herniation and spondylolisthesis, which we know is not going to get better with some conservative therapy. B is incorrect because this is not an emergency, and he does not have signs of Cauda-Equina syndrome, so we do not need to emergently call a spine surgeon for this. And C is incorrect because we do not need any imaging with CT, as we already have an MRI, so it would just be a little redundant and unnecessary to get that. So that leaves our best answer as D, referral to a spine surgeon for decompression and fusion, because he will need to be decompressed for the radiculopathy going down his leg, and likely a fusion due to his grade 3 spondylolisthesis. And lastly, for case 3, we have a 54-year-old female who presents to the ED who was complaining of the worst headache of her life and had rapid deterioration of her consciousness witnessed by her husband. On arrival, she has a GCS score of 6 and was already intubated by EMS, and she's only flexing her upper extremities to pain. What imaging do you obtain first? A, MRI brain with contrast. B, CT brain without contrast. C, CT angiogram head and neck, and D, CT brain with and without contrast. So I'll give you a second to think of what answer you want to choose. And the answer in this one is going to be B, a CT brain without contrast. This vignette is giving us clues towards her having a subarachnoid hemorrhage, especially with that worst headache of her life and then rapid deterioration of her consciousness. So you're going to get a CT first. It's the quickest, easiest, fastest way to scan her head and see what's going on. While in her hospitalization, you may get an MRI or even a CT angiogram to see why she's having the subarachnoid. It would not be the next best step. So just something to keep in mind when you have an emergency and you have concern for a brain bleed, that you're going to get a CT without contrast first.